Hello there, my name is Priyal Taribagil. I have recently graduated from UCL Medical School and will be starting my academic foundation training program in London. The aim of today's tutorial is to provide a greater insight into retinopathy of prematurity. In particular, I will be talking a bit about the theory behind the condition, staging, risk factors and screening, management, and complications. I'd like to start off this tutorial with a quick case study just to get you all thinking. The scenario is as follows. A female baby with gestational age of 26 weeks and a gestational weight of 1,000 grams presented with respiratory distress syndrome. She was started on supplementary oxygen and received surfactant therapy. On examination, leukochoria was noted. This is a classic case of an infant that is extremely high risk for developing retinopathy of prematurity. Often patients do not have many signs or symptoms, therefore it is pertinent not to overlook this as a diagnosis. The theory behind ROP. ROP is a condition that affects blood vessels at the junction of the vascular and non-vascularized retina. This mainly affects premature infants that receive postpartum oxygen. Normally, blood vessel development begins at the optic disc and spreads out peripherally until around 40 weeks. However, in premature babies, this development is incomplete, resulting in abnormal vessel growth, membrane formation, and retinal detachment. Furthermore, normal blood vessel growth occurs in areas of low oxygen concentration. If excessive supplemental oxygen is given, normal blood vessel formation is stopped. This further triggers the release of VEGF, vascular endothelial growth factor, which then stimulates abnormal new vessel formation. The diagram on the right demonstrates blood vessels coming out of the optic disc. The extent of blood vessel growth can be defined by zones. This is beyond the scope of the tutorial today. However, the zones are often used by ophthalmologists to identify the degree of ROP. Staging ROP. ROP is classified into 5 stages, ranging from mild, which is stage 1, to severe, that is stage 5. Stage 1 ROP involves the presence of a demarcation line. This can be seen in the diagram above. This is a white line that marks the border between vascularized and avascular retina. Stage 2 ROP is when the demarcation line develops into a ridge between the vascular and avascular peripheral retina. Stage 3 ROP occurs when there is fibrovascular proliferation in the ridge itself. Stage 4 ROP occurs when there is partial retinal detachment due to tractional forces created by the new vessels. And finally, stage 5 ROP is defined as the presence of total retinal detachment. Risk factors and screening. The main risk factors associated with ROP include prematurity, so the greater the degree of prematurity, the higher the risk of developing ROP. Low birth weight, in particular those babies that have a birth weight of less than 1,500 grams. Supplementary oxygen. Premature babies are often given high flow oxygen in order to manage other complications such as respiratory distress syndrome. This oxygen, however, can lead to increased production of VEGF, which in turn increases abnormal vessel proliferation. Hypoxemia. Paradoxically, this is also considered to be a risk factor. Therefore, both high oxygen and very low oxygen concentrations at different stages are thought to contribute to ROP. Target saturations of 85 to 90% is a good compromise in order to minimize the risk. Symptoms. These are often not present. However, in very severe ROP, An infant might develop leukocoria, which are white pupils. Other differentials for this include congenital cataracts or retinoblastoma. These must also be ruled out. Screening guidelines. All babies with a birth weight of less than 1,500 grams or those with a gestational age of less than 32 weeks should be screened. This will be achieved by using a dilated fundoscopic examination, particularly looking at the peripheral retina. The first set of screening is often carried out between 4 to 6 weeks. Monitoring and treatment will be dependent on the stage of the ROP. Management. Peripheral retinal ablation. The most common treatment used in ROP is laser therapy. The goal of this is to prevent further progression of the retinopathy of prematurity and to help reverse the growth of any abnormal blood vessels that have already formed. This is achieved via the use of a diode laser which creates tiny burns on the periphery of the retina, in the region of the avascular retina. In the past, cryotherapy was used. However, this has been superseded by the introduction of this laser therapy. If ROP has failed to regress, retreatment should be performed roughly 10 to 14 days after the initial treatment. Further management options. Scleral buckling and intravitreal injections may also be considered in the management of ROP. Scleral buckling is a technique that is commonly used in the treatment of retinal detachment. The procedure involves inserting a small silicon band close to the ridge. This can be tightened to prevent the retina from detaching and the ROP from progressing. This is considered for very severe cases of ROP, stage 4 and stage 5. Vitrectomy can also be done in order to supplement this. Other options include the use of intravitreal injections, such as bevacizumab or Avastin. These are anti-VEGF specific injections that help to reduce abnormal blood vessel formation. Complications of ROP. If left untreated, ROP can lead to refractive errors, retinal detachment, amblyopia, glaucoma, and ultimately blindness. Therefore, timely diagnosis and management is key. To summarize, we have talked through the pathophysiology, staging, and classification of ROP. We have also discussed various treatment options that are used in clinical practice. I have put together a list of resources that I have used to make this video. Thank you for watching this tutorial, and I hope you have found it useful.